randomized control trial to try to invent, let's say, therapeutic approaches to really treat patients with long COVID. And I'm looking forward to the newest results. I'm not sure whether you can show, but yeah,
not yet.
Let's see. Keep the tension up.
Exactly.
Thank you very much for joining us today.
Thank you very much for this fantastic introduction. I'm absolutely delighted to be able to talk to you about the MyFlame-19 study. I am a cardiologist, physician, and also clinical pharmacologist, and I have joined Professor Eichenagel a long time ago to not just do the pretty images, but also develop the therapies which can be guided by imaging, perhaps in the earlier stages. It took me a long time to come to the point where I am today. So proud that I can tell you about a clinical study, clinical trial that does exactly that. These are my disclosures. So the study design and rationale, we've published this, it is out in the open, so if you cannot catch everything that I'm going to be talking about today, it's out there. Also for my lovely patients that I know very well, I have done a little bit of a subtitles underneath so that things can be perhaps also in retrospect looked at. So I will come today with a hypothesis, obviously, that we are working on. We understand that patients are very, very different, individual, needs to be also understood a lot more deeper than just with one biomarker, with one measurement. This is a complex disease. We believe that there is a common denominator in the background, and this is the endothelial dysfunction. So we know, and there are fantastic reviews out there to which I'm guiding you here, that SARS-CoV, not the virus, but the spike protein, so its long arm, internalizes into the cells. And I'm going to focus here on what happens on a level of vessels. So it enters into the endothelial cells and produces inflammation here on the right-hand side. You can see the rise in interleukin-6 MCP1 within hours of being internalized and producing it. So virus does not have to be present anymore, spike protein does it for it. And by this also not just induces the endothelial cell inflammation, but also in the bottom graph here on the right-hand side, endothelial cell microparticle formation. So I will show you a lot of evidence that comes from other people that ties very nicely with what we do, what we think. Outstanding study from the hands of Harry Heidecker, so very important researcher in our German community, who developed the ELISA autoantibody test that we have already translated into clinical practice, not yet supported by the insurances. However, very useful in understanding this part of vascular autoantibodies. So renin-angiotensin system activation, endothelial dysfunction, vascular antigens presentation then induce subsequently what perpetuates this inflammation, vascular autoantibodies. Again, very targetedly at the level of renin-angiotensin system. So this. Also additional studies, so additional support to this hypothesis from another group, showing the role of these autoantibodies in vasoderegulation, which we often also see with the patients, either high blood pressure or very low blood pressure, so vascular permeability being a real problem. Another study from the Italian parts showing that, yes, it is this inflammation, these processes are sufficient also to produce end organ damage. Again, I'm showing you things on a cardiac level that also happens elsewhere, as in neuro, renal, and so on. So this is not just limited to the heart. But here you can see patients with cardiac dysfunction have also produced own cardiac self-antigens sufficient to, autoimmunity against them, sufficient to cause cardiac dysfunction. When these serums have been introduced into the animal model, they have developed with time cardiac dysfunction, so really validation of this hypothesis. And perhaps the most important for us to translate, what does it mean, vascular dysfunction, endothelial dysfunction leading to vascular dysfunction, that this actually affects patients very, very much physically. Here, an excellent study, only a letter from the lab of Inigo San Millan, a very important sports medicine researcher, comparing patients with metabolic syndrome, so a little bit on a biggish side, people that are active but not athletes, against patients with post-COVID. The red ones, those with comorbidities, the blue ones, those with no comorbidities, which are our patients, but we're going to come to this later. So when we exercise them, we can see that with the, here's my mouse, with the increase, first let's look at the metabolic syndrome and the moderately active, that with increase of exercise, they slowly increase the power output. But also, there is a slight rise in lactate, so they can compensate. They move from aerobic zones through the zone where mitochondria still can tolerate lactate, so metabolic flexibility persistent. And then eventually, yes, they do move in zone 3, where lactate rises considerably. But this is not how things are in long COVID. In long COVID, a little bit of exercise pushes lactate sky high. This is what is the background to them being so unwell when we put them on a treadmill, when we push them through spiro-ergo, cardiopulmonary exercise testing. It all comes with a delay, PEM, post-exercise malaise. We push them beyond the capacity for them to tolerate lactate. So I would really like this to be sort of framed in your minds, that exercise in long COVID is actually causing harm. So our hypothesis is post-COVID condition is, at least in part, spike protein-induced renin-angiotensin system activation, which leads to autoimmune endothelial microvascular disease, endothelial dysfunction, hypoxemia, tissue hypoperfusion, leading to mitochondrial dysfunction, cyanosis, COVID fingers, lactate acidosis, PEM. I'm introducing you to the concept of MARFLAME study. MARFLAME is a multi-center randomized, double-blind, controlled clinical trial of 280 patients with long COVID, cardiac symptoms, most commonly tachycardia, chest pains, shortness of breath on minimal exertion. They pace themselves. Sometimes the shortness of breath is not so apparent. Who have no pre-existing cardiac conditions, so no structural heart disease. So they are not cardiac patients in classical sense and have not received any medication. Most of them are like that. They undergo baseline cardiac MRI to, again, verify they have not got structural heart disease. If they do, we send them back to our colleagues. And they have MR findings of inflammatory cardiac involvement. Here are our criteria, and I'm going to speak about this in a minute. What does this mean? We treat them for 16 weeks in a double-blind fashion, placebo control. And then they undergo another cardiac MRI to see whether this was in any way effective. 16 weeks is not enough for them to recover. 16 weeks is enough that we can use cardiac MRI to see, to confirm they are on the right track. That's why we go and treat them with the help of our colleagues, GPs, so Hausärzte, for another up to a year, and at that point, they are also much better. This study is supported by Bayer, and we are all supported by DZHK. We have concluded our recruitment, and I'm hoping to be able to tell you about the results at the end of the summer. Coming to cardiac MRI, this is our work, previous work, that have been already giving us clues these patients may not have structural heart disease, yet they have inflammation. For us, these particular images are déjà vu of what our previous studies in autoimmune conditions have shown. Raised T1, raised T2, edema, perimyocardial late gadolinium enhancement, no necrosis, but inflammation, and obviously in the background, microvascular disease. So I will quickly explain what does it mean, no necrosis. Necrosis, scar, myocardial dysfunction, structural heart disease. These are the late substrates that we at the moment are able to see, able to work upon, able to act upon in line with our cardiology guidelines. This is not what we do in MyoFlame study. We are after the early substrates. So here you can see mitochondrial signals, stress, that translate in osmotic swelling of the mitochondria, intracellular edema. And yes, you do have to have incredibly sensitive methods. This is nothing off the shelf from Siemens and Philips and GE and so on. These are the methods that we have worked on very, very hard for 15 years, made sure that they perform when we need them. We also are working on translating them, making them available to the hands of many. That is not just where we are today. T1, very sensitive measure of abnormal myocardium. T2, specific for water. When they are up together, as we can see here, I can't see my mouse, here in this context, they tell us about intracellular swelling. This is what we see also in patients with COVID. In conclusion, MyoFlame 19, blueprint of cardioprotection study. No structural heart disease, yes, inflammatory signals, as I've shown you, aiming to prevent development of structural heart disease. In a selected population, we have defined them through phenotype, through cardiac MRI, T1 and T2 mapping, using these highly precise measurements. And we are using existing drugs with good efficacy, a known pathophysiological profile to target what we think is the problem, endothelial dysfunction. With this, I would like to thank you all, and especially patients groups that have been enormously supporting us. Thank you so much again.
Good morning. Thank you very much, Valentina, for a great overview, great talk. So we have time for an urgent question. Is there a question? So I have one. You saw a lot of patients, I know, and with you, based on your experience, sometimes we see this patient with quite some inflammatory signs in the MRI afterwards, but not yet cardiac systems or exercise tolerance. How should we deal with those in your experience?
So with cardiac MRI?
So you see the changes in the cardiac MRI, but from the symptomatology, they are still quite okay, so you would not call it yet cardiac symptoms or exercise, or they don't have experience in exercise intolerance, but you see the lab changes and you see the MRI. How should we deal with those?
So this is the group that is not MyoFlame population. I must say, most patients in MyoFlame have very, very severe symptoms. When the symptoms are mild, first things first, it's not just about drugs, it's also about lifestyle changes. They have to learn everything about pacing, and I'm grateful here to patients' organizations that have also listed what they should do. I will just quickly go back to this one. Please do frame this in mind. How important it is to understand vascular damage, how quickly they can push themselves. This is not about fitness. This is not about trying to increase the mitochondrial capacity. No. This is about getting the vessels not to be damaged by doing too much, by lactate in the aftermath. So pacing is the first measure, drugs as the next, and drugs do work. Thank you.
Thank you very much, Valentina. It was a great talk. And as we heard, thrombo-inflammation is very central in the sequelae of long COVID, and I'm happy to announce the next speaker from Munich, Konstantin, who will present on thrombo-inflammation and COVID-19. Konstantin.
Yeah, thank you for the nice introduction, and we will stay in the cardiovascular field, but I will talk more about mechanistic studies and how they show that thromboinflammation might be something which is involved not only in COVID-19 but also in long COVID. So we have heard that long COVID is heterogeneous, it is a syndrome, and there are multiple clinical manifestations of long COVID, which range from neurological to cardiovascular, and I will focus more on the cardiovascular manifestations. But this also, as said, suggests that this is not only heterogeneous from the presentation, but also from the mechanisms. So there are numerous potential mechanisms of long COVID, and probably these are not working in parallel, but these are probably a chain, and these are interconnected, but they might be very different in different patients, which then have different symptoms. What I will focus on is blood clotting and endothelial abnormalities, but this is not isolated. So this is something which is embedded into the other pathologies underlying long COVID, which is autoimmunity and immune dysregulation. And this might even be connected to neurological dysfunction, and I will show you some data on that. So what is thromboinflammation? So thromboinflammation is a process which is designed as host defense mechanism. So we all know that when a virus attacks us, the immune system gets activated, but this is not the whole story, but also the clotting system and platelets get activated. And this is a mechanism how the body prevents the dissemination of pathogens in the body. And this has a lot of advantages, but it has one disadvantage, and this is that the blood vessels might get blocked, and this causes tissue ischemia, tissue damage. So in the end, there's a tight interplay between coagulation, complement, platelets, innate immunity, which finally results in clot formation. And these clots might not only have an acute effect, but also a long-term effect, which I will go on later. So initially, we had clinical manifestations of COVID, which ranged from mild symptoms to hospitalized patients and very critically ill patients. And interestingly, this is also paralleled by vascular processes. So in the mild disease, we have no evidence of clot formation in the microvasculature, but in the critically ill patients, there was a lot of thrombotic complications, but also microvascular dysfunction. And this is connected by thromboinflammation. So the viral hit, which we see here in the computed tomography images we got used to, shows that there's a lot of inflammation going on in the lungs. But also this results in the blockade of blood vessels. And these blood vessels are not only blocked by clots, but these are full of inflammatory cells. And as said, this is not only something happening in the lungs, but this is a systemic process. So we see processes in the lung, but also in the heart and the kidney. So indicating that this is really a systemic effect of activation of thromboinflammation. This is a more detailed scheme on what happens in the body and how this connects the respiratory failure in patients with systemic coagulopathies. So when the virus gets into the body, it activates endothelial cells, activates platelets, neutrophils, and these form then clots in the microvasculature, which then gets apparent as respiratory failure in the patients, but also causes a systemic coagulopathy, which then results in an increased risk of cardiovascular diseases as stroke, myocardial infarction, and pulmonary thromboembolism. So could complement be a target? So what we saw in patient samples is that platelets really form aggregates with antibodies, but especially with complement factors. And I showed you that complement is critical for activating not only platelets, but can also activate the immune system. So it could be a link between inflammation and thrombosis. And from patient samples, we saw that D-dimer levels correlate with activation of the classical complement pathway. So it could be the complement activation is then the bridge to activation of the coagulation system. And we tried this in mice, and we saw that when we block classical complement activation, the formation of these pulmonary thrombi was decreased, going back to non-infected levels. But one has to be cautious because this is data in mice, so this is no evidence in humans, but I will talk about the complement system later on to convince you that this might be something to look into closer. Okay, so this was acute COVID-19. So what is the connection to long COVID? So we know that there's persistent vascular dysfunction in long COVID. There's hypercoagulability. There's not only microvascular, but also microvascular thrombosis. And there are different levels of evidence, one from epidemiology, others from biomarkers, and also from experimental studies. And I will guide you through these different evidence levels. So this was a study which I think drew the attention of many cardiovascular researchers that even though the acute infection was gone in patients, they still had a high risk of thrombotic events within 1 year after COVID infection, even if there was no virus present. However, one has to be careful in this study because this was performed without vaccination very early on in the pandemic on male veterans. But it shows that there are deep results in the cardiovascular system from the acute infection, and that the risk for thrombotic disorders also depends on the initial disease severity. So patients which had a mild disease had a lower risk, but still they were at risk. But especially critically ill patients had a really high risk of cardiovascular events after infection. But there's also experimental evidence for a role of thrombo-inflammation in long COVID and beyond the acute infection phase. So fibrin, as you all know, is central for clot formation, but it also promotes neuroinflammation and neuronal loss after infection and is connected to lung pathology. And this was a study published last year in Nature, and they showed that when they incubated plasma with fibrin strands, as you see here, with infected plasma, the spike protein of SARS-CoV-2 attached tightly to fibrin. And this forms like a toxic combination, causing then, in the end, the deposition of fibrin and spike protein in the vasculature. And this drives systemic thromboinflammation and neuropathology in COVID-19, as they show experimentally, one has to say. So they also used an antibody blocking for this pro-inflammatory effect of fibrin, also in mice, so there's no human data. But they showed that by blocking this, they could attenuate not only lung pathology, but also brain pathology in these mice, showing that thromboinflammation might be a target not only for the acute setting, but also for the long-term sequelae of COVID-19. What are the biomarker evidence levels for thromboinflammation in long COVID? So this is a study also from last year published in Science by another group. And they followed up COVID patients and did a really deep clinical phenotyping, measured a lot of proteins in the serum, and they found that complement and thromboinflammation markers are the top biomarkers for active long COVID. So C5, C7 are parts of the complement system, and von Willebrand factor, LMSTS13, are parts of endothelial activation. So indicating that indeed thromboinflammation might be something to look at. However, as said, they got a little bit deeper into that, and their conclusion is that long COVID is accompanied by a blood signature marked by increased complement activation, as shown here. They showed that there's especially activation of the terminal complement pathway. They showed that there's ongoing thrombo-inflammation, including activated platelets, which form aggregates with monocytes, activating the clotting system. And there's also evidence of tissue injury as well as markers of red cell lysis. And this was interestingly also connected to increased response to other viruses like CMV and EBV elevated antibody levels. So this seems to be, as I said, connected to other mechanisms in the body of host defense, which then result in thromboinflammation in the end. What are the implications from that? So I think an early cardiovascular assessment of long COVID patients is necessary to exclude that there's a really obvious cardiovascular disease resulting from COVID infection, as we know that this is a risk factor for cardiovascular diseases. And this is, I think, more speculative, but the authors from this study concluded that antivirals targeting SARS-CoV-2 or even herpes viruses could reduce thromboinflammatory responses, and that complement therapeutics might be a way to affect long COVID. Also, the evidence here is lacking from the study. But this is an idea which might be followed up in the future. So, as I said, there are numerous manifestations of long COVID, and one is dyspnea, breathlessness. And this was another study showing, going into the different phenotypes and how they correlate with blood biomarkers. And one thing which stood up also when they looked into the association of biomarkers with breathlessness in long COVID was the activation of platelet pathways like thromboxane and PDGF receptor beta. So there's, I think, compelling evidence that thromboinflammation might be part of long COVID. Also, we don't know if it's just a part of a chain, just a biomarker, or if it's a causal link. So to sum up what we know about thromboinflammation in long COVID, thromboinflammation is certainly associated with long COVID, linking several pathomechanisms, but we don't know if it's associated with specific subtypes, if it has a causal role or is just a biomarker or part of a chain of events. If it might even be a therapeutic target, I think there we need more evidence to claim that. But certainly the cardiovascular community needs to be aware of these patients and really has to have a long-term look at them to see how we can help these patients. And with that, I would like to thank you for your attention and the team, which was really interdisciplinary. And it was a great experience to work on this with so many disciplines in the field, and obviously also the DZHK for its support. Thank you.
Thank you very much, Konstantin. Are there questions to the talk? Yes, please.
Thrombo-inflammation, which one would you think would be the most useful to monitor in the clinical setting? I mean, there's some ideas of looking into nets or, of course, microclots related to in plasma poor or depleted from platelets, microclots. What is measurable? What could we measure in the clinic as a biomarker from your perspective?
Yes, well, this is going into the questions about which one is best in the clinics. And this was the study here, and they showed that specific complement factors might be something to look at, as well as markers of endothelial activation. But of course, this is a specific setting, and this is not specific to long COVID. So I think this is the point, that even if we measure these factors, we cannot sure if it's long COVID or if it's just another infectious diseases. But I think it's rather not a single marker, but maybe a biosignature. I think it's more a pattern than a single target.
There is a broad use of anticoagulation, platelet inhibition epidemiologically. Can we learn anything from these data discriminating as to thrombo-inflammatory events?
Yeah, so this is a really good point, because there were also early in the pandemic hopes that targeting coagulation in platelets could be something to prevent the severity of disease, but the evidence is rather low. So that's why I think that just targeting classical complement coagulation in platelets is not the way to go. I think we need to have something targeting thromboinflammation specifically, and their complement might be something to look at. Also, we have to be reminded that complement inhibition might then affect the immune system, causing immunosuppression. But I think the data for antiplatelet therapy and anticoagulants are rather disappointing.
Just a very quick comment. A lot of patients use nattokinase, which is actually anticoagulation therapy. They perhaps do not necessarily understand that this is, yes, sold as a supplement, but we actually do not have necessarily the safety profile for this drug. Wouldn't it be a good idea that we, as soon as possible, do some sort of a study where we also understand whether these drugs are at all useful, so efficacy as well as safety, and perhaps go into the profile of the anticoagulation drugs that we already have that are licensed for this use? I would much rather, with a clear indication, use rivaroxaban and things that we know very well from the safety perspective than nattokinase, where I don't know what is going to happen. So it would be informative for the patients to know what to do, and obviously also the doctors.
Yeah, so I cannot recommend the plain use of anticoagulants for every patient, but I think that's a question of which subtype of patient. Maybe there are subtypes of patients which have a really strong thromboinflammatory activation, and they might actually benefit from that. But as said, the evidence for just using anticoagulants is rather low. And I think that this is because this is something which is going in a chain and not going in parallel, and probably we have to pick the right place in the chain to really disrupt the pathomechanisms.
One last question.
So you showed the effects in the acute infection in the beginning. Is there any idea what in the long COVID situation could drive the thromboinflammation? After 1 year, would you suggest that there's autoimmunity or still virus there?
Yeah, so probably there's an autoimmune dysregulation, which also comes from reactivation of other immune processes, like to other viruses, and also the persistence of endothelial dysfunction and also fibrin clots in the circulation, which then could be a remnant driving autoimmunity, because we know that coagulation feeds back on autoimmunity and vice versa, and this is probably a vicious circle, and which then results in this, could result in these symptoms. Yeah.
So thank you very much. There in the coffee break we'll have more time to ask questions to Dr. Stark, but for a matter of time I would go ahead. So our next speaker, Carsten Schömer, was unfortunately... Thank you first, yeah. Thank you. So our next speaker, Carsten Schömer, was unfortunately on sick leave, but he is giving us a talk hybrid online today. Unfortunately, we were not able to manage yet the connection, and this will be likely put after the coffee break, if that works. And I'll hand over now to the next chair, Silke Andrich from the DZHK.
Yeah, good morning from